Hello everyone, myself Neha Laxman kirpan from Shivajirao S. Jondhale College of Pharmacy, Asangaon, studying in second year B Pharmacy. Today I am going to present a pharmacology topic, that is Opioid Analgesic and Antagonist, under the guidance of Dr. Nitin Mohire as a professor and principal of our college. Here we see the introductory part about opioid analgesic and antagonist. Pain is an ill-defined, disabling event associated with many medical conditions. The sensation of pain is called analgesia. Drugs which inhibit sensation of pain are termed as analgesic. Opium was the first natural analgesic. Derivatives of opium are termed as narcotic or opioid. Some background about pathophysiology of pain. Endogenous opioid peptides and opioid receptor is desirable. Then pathophysiology of pain. There are two components in pain reception, the nociceptive and the affective. The nociceptive component is disabling, unpleasant sensation evoked by noxious stimuli and conveyed to CNS by ascending pathway. The affective component is the psychological response towards the pain and convey from CNS to the dorsal horn by descending pathway. The physiological basis of pain and the sites of action of drug which relieves pain are: noxious stimuli stimulate nociceptive receptors of sensory nerve ending in pain-sensitive tissues. The stimulation is mostly chemical in nature. The pain, including endogenous, are released during inflammation, tissue injury, ischemia, and by thermal or mechanical stimuli. The endogenous substances include histamine, ACH, bradykinin, and calidin. The sensation from pain receptors are transmitted through sensory afferent nerve to the dorsal horn of spinal cord. Substance P may be the neurotransmitter for relay of nociceptive impulses. The signals are proceed and transmitted via ascending pathway in the spinal cord. Signal received in the thalamus, brainstem, reticular formation, and periventricular gray matter are processed and transmitted to the sensory cortex, where pain is finally perceived. Pain processing by the dorsal horn is subject to modulatory influences by gate control mechanism. Thus, inhibitory influences are exerted by activity in other peripheral sensory neurons and descending pathways from midbrain and brainstem. Opioid analgesic act on the spinal cord and brain, where they inhibit pain processing at the dorsal horn and increase the threshold for pain perception by central pain centers. Endogenous opioid peptides. Three types of endogenous peptides with analgesic activity are endorphins, enkephalins, and dynorphins. They are derived from distinct precursor polypeptides. They are involved in modulating pain and form part of the complex pain inhibiting mechanisms in the brain and spinal cord. These peptides have also been involved in genesis of psychiatric disorders, in control of autonomic and neuroendocrine function, both under the normal and stress condition. Opioid receptors. The four major endogenous opioid receptors have been identified. They are mu receptor, K, that is kappa receptor, delta receptor, and sigma receptor. The mu, K, and sigma receptor mediate main pharmacological action of narcotic analgesic. Mu and K receptors are important for analgesia, while sigma receptors are responsible for psychotomimetic effect. Delta receptor inhibit excitatory neurotransmission in the brain and periphery. Based on receptor activity, drug acting on opioid receptor can be categorized as follows. Agonist. They are subclassified based on chemical modification in the structure of morphine. Morphine analog are heroin and codeine. Methadone derivatives is dextropropoxyphene. Thebaine derivatives is atropine. Phenylpiperidine derivatives are pethidine, fentanyl, supentanyl, and diphenoxylate. Mixed agonist antagonist. They are also subclassified on chemical modification in the structure of morphine. Benzomorphan derivatives are pentazocine and cyclazocine. Morphine analog are nalbuphine and buprenorphine. Morphine derivatives are levolorphan and meptazinol, and other are antagonists. Opioid analgesics, drug having agonistic activity, especially on mu receptors, are usually used as morphine is a prototype drug in this category. Action of morphine are discussed below. Pharmacokinetics. Morphine is readily absorbed from GIT. The drug is usually administered by intramuscular route. Half-life is 2.5 hours and duration of analgesia is 4 hours. Morphine is metabolized by N-dealkylation and oxidation followed by glucuronide and sulfate conjugation. Metabolism are excreted in urine. Mechanism of action. Morphine acts through different receptors. In addition, it influences the activity of some neurotransmitter in brain. It increases cholinergic and 5-HT activity and inhibit noradrenergic, dopaminergic and GABAergic activity. It releases histamine but inhibit release of substance P. Then we see pharmacological actions. Analgesia. Beside raising pain threshold, morphine reduces emotional reaction to pain. This eliminates stress caused by pain and helps the patient to tolerate pain better. Then sedation. Morphine induces sedation in analgesic doses and is useful when pain is accompanied by insomnia. Then nausea and vomiting. Nausea and vomiting observed along with analgesic effect of morphine and are due to stimulation of CTZ. Higher doses of morphine inhibit CTZ. Morphine emesis is not blocked by DA antagonist like prochlorperazine but is inhibited by opioid antagonist naloxone. Then neuroendocrine effect. It increases release of ADH, decreases release of ACTH, growth hormone and gonadotropin together with increased plasma prolactin level. Morphine related drugs. First, pethidine. It is less potent morphine as analgesic but causes equal respiratory depression and vomiting. It has shorter duration of action. It is less sedative and constipating agent. It is used as an analgesic and pre-anesthetic medicament. Then heroin. It is more effective than morphine as analgesic. It is metabolized to morphine in brain. It is most addictive and not used clinically. Third one is methadone. It is equipotent to morphine with an advantages of being oral active and longer duration of action. It is used in the treatment of morphine de-addiction. Then fourth one is atropine. It is analog of morphine with 1000 times more potency than morphine. It is mainly used to veterinary medicine and for trapping wild animal. Then fifth one is codeine, sixth one is pentazocine, seventh one is tramadol, and eighth one is naproxen, and ninth one is phenytoin. These are the structures: morphine, codeine, pentazocine, heroin, naloxone, papaverine, and naltrexone. Then we see opioid antagonist naloxone. It is small mu receptors antagonist, moderate antagonist at K receptor, and a weak antagonist at delta receptor. It has fast onset of action with a plasma half-life of 1 to 2 hours. It has an extensive first pass metabolism which reduces its bioavailability. It is primarily used for the treatment of opioid overdose, also normalize respiration, level of consciousness, pupil size, bowel activity, and awareness of pain. Then it can also be used as a diagnostic test for a test of opioid addiction because of instantaneous action. It is also used to revert neonatal respiratory depression due to opioid used during labor. Naloxone is available as 40 mg per ml injection, that is Nalox or Narcotan. Then second one is nalmefene. It is a derivative of naltrexone but can be used only intravenously. It has a quick onset action but plasma half-life is longer than naloxone. It can be used like to treat opioid overdose. It lacks hepatotoxicity. It is also used approved for treatment cholesteric pruritus with a dose of 20 mg twice a day. Then third one is alvimopan. It predominantly blocks peripheral mu receptor in the gut. It has been approved for relieving constipation of an opium addict without risking the precipitation of opiate withdrawal. It is also used to treat post-operative paralytic illness following bowel surgery. These are the reference links that are used. We are thankful for our President, Honorable Dr. Shivajirao S. Jondhale, Secretary Honorable Dr. Geeta Khare, and Principal Dr. Nitin C. Mohire for encouraging us to make it informative videos and proper use of social media to spread the information. For more informative videos, please like, share and subscribe. Thank you.